Hello and welcome to 22q11.2, a tiny piece leading to a big picture, brought to you by Chromosome 22 Central as part of the month-long 22q awareness celebration. My name is Donna McDonald-McGinn, and I'm a professor of clinical pediatrics at the Perelman School of Medicine of the University of Pennsylvania in Philadelphia. I'm director of the 22q Center, Associate Director of Clinical Genetics, Chief of the Section of Genetic Counseling, all at the Children's Hospital of Philadelphia in Philadelphia, USA. I'm also a founding board member of the International 22q11.2 Foundation, which is located in Matawan, New Jersey in the US, and I'm a founding trustee and current chair of the 22q11.2 Society, which is the professional organization interested in chromosome 22q differences based in London, the United Kingdom. So for those of you who aren't familiar, Philadelphia, also known as the City of Brotherly Love, is located strategically 1 hour from New York City, 2.5 hours from Washington, D.C., 1 hour from pristine beaches, and 2 hours from beautiful mountains. So if you come to the Northeast United States, please stop by in Philadelphia because you won't be disappointed. So before discussing the 22q11.2 deletion and duplication syndromes, we need to talk about chromosomes. And before discussing chromosomes and genes, we need to back up and talk about cells. All living things are made up of cells, including this leaf where the cells are visible as boxes. All humans, likewise, are made up of cells. And chromosomes are located within the nucleus of the cells. Chromosomes are visible under a microscope, and we expect to find 46 chromosomes in each cell. They come in pairs, so that would be 23 pairs, and one of each pair is contributed by each parent. We take a photo of them, we match up the pairs, and we call it a karyotype. Within a karyotype, the chromosomes are numbered from the largest, number 1, to the smallest, number 22, and they include the sex chromosomes. So here we have an X and a Y, which is seen in a male karyotype, and females have 2 X's. All chromosomes have a top half separated by a waist known as the centromere. And chromosomes were first described by the French, and they noticed that the top half of the chromosome was always a bit shorter than the bottom half. So they called the top half the P arm, or petite in French, and Q follows P in the alphabet, so the bottom half of the chromosome is the Q arm. Chromosomes are further defined by a numbering system that names the individual bands or stripes when stretched out like an accordion, and this creates a universal language for those of us in genetics. So 22q11.2 is completely different than 22q13.3, which is way down here. Chromosome bands are like the boxcars on a train, so if a boxcar is missing or extra, we see it under the microscope. Likewise, if a band is missing or extra, we sometimes see it under the microscope, but not always. Importantly, the genes are the packages inside, so if a chromosomal band is missing or extra, genes are missing or extra. And genes set up a blueprint for the body. They determine our hair color, our eye color, our height, etc. Now, chromosome 22q11.2 differences involve missing or extra genes that we call copy number variants, or CNVs. There are approximately 50 genes within the 22q11.2 region, including the important developmental gene TBX1. These genes affect cells in the developing embryo. So for example, genes in the 22q11.2 deletion can lead to structural abnormalities of the heart with the resulting congenital heart disease, absence or underdevelopment of the thymus leading to immune problems, and underdevelopment of the parathyroid glands leading to hypocalcemia. Now, I hear families talk about 180 or 200 findings associated with the deletion, and I find that that's a little bit overwhelming for anyone. And so I like to think about common, significant associated features, and then rare but significant associated features. So in the vast majority of individuals who have the deletion, we see immunodeficiency, including low T cells and immunoglobulins, humoral deficits, meaning that once a person is vaccinated, they haven't mounted a response to that vaccine, allergies, and asthma. We see congenital heart disease quite commonly, and half of the individuals that we see at the Children's Hospital of Philadelphia have severe defects, mostly tetralogy of Fallot, with or without pulmonary atresia, and interrupted aortic arch type B. And then we see, again, the vast majority of individuals with palatal abnormalities, but this mostly includes submucosal cleft palate or velopharyngeal incompetence. So when you look in the mouth, you don't see a big hole, which is what we would call an overt cleft, and we generally don't see cleft lip and or palate. So in fact, only about 10% of our patients have a hole in the palate, and only 1 to 2% have a cleft lip. We also know that gastrointestinal feeding and swallowing problems are quite common, mostly gastrointestinal reflux disease, difficulty feeding and swallowing, and constipation. And then we sometimes see things like an absence of the anus or Hirschsprung's disease, where there's not normal innervation in the bowel, or intestinal malrotation that can lead to significant feeding problems. About half of the patients we see have endocrine abnormalities, including low calcium, thyroid disease, and a subset with growth hormone deficiency. And then more than half have skeletal abnormalities, including differences in the vertebrae in the neck, which is important, especially for anyone who wants to do any sports that might put the neck at risk, such as downhill skiing, gymnastics, diving, football, those kinds of things. And about half develop scoliosis, and about a quarter of those individuals need a surgical repair. And then we see kidney differences, mostly single or dysplastic kidneys, meaning that they're not formed properly. And so we recommend a renal ultrasound in everybody who has the 22q11.2 deletion. Now, less frequent but significant features of the deletion include other skeletal differences, so abnormalities of the vertebrae lower down in the spine, not necessarily in the neck. Craniosynostosis, so premature fusion of those sutures of the skull, and so we might not see a normal fontanelle or might not see the skull growing properly, and some limb differences such as extra fingers or toes. We see differences in the brain and spine, including seizures unrelated to low calcium, a smoothness to the brain in a subset of individuals, spina bifida in a small subset, a small head circumference, low tone, stiffness of the limbs known as dystonia, and in a subset of individuals, Parkinson's disease. We also see autoimmune disease, and we think that this is immune mediated, meaning related to the immunodeficiency, and this includes differences in the platelets known as idiopathic thrombocytopenia, differences in the joints, particularly juvenile rheumatoid arthritis, low thyroid, high thyroid, type of anemia known as hemolytic anemia, neutropenia, and the changes in pigment in the skin known as vitiligo. We also see other genitourinary abnormalities, so hypospadias, where the tip of the opening of the penis is not at the tip but underneath, cryptorchidism, where the testes haven't descended, occasionally an absent uterus in women, and hernia, including around the belly button and in the groin. And then ENT differences in addition to chronic ear infections and sinus infections. We see a laryngeal web, which can cause a breathing problem, choanal atresia, where there's not an opening from the nose down to the throat, a connection between the trachea and the esophagus known as a TE fistula, an abnormality where the trachea isn't formed properly at all, so the person couldn't breathe, small ears known as microtia, hearing loss, both sensorineural and conductive, and sleep apnea. And then we see some eye findings that are important, including coloboma of the iris, so you can see where that pupil isn't round, sclerocornea, which is an eye emergency, so these individuals need a corneal transplant, ptosis, which is a droopiness of the eyelid, and then some muscle problems such as strabismus. And then we also see tortuous retinal vessels, which are a clue to the diagnosis but don't cause a problem, and something called posterior embryotoxin, also a clue to the diagnosis but doesn't cause a problem. And then lastly, we see some patients with malignancies more prevalent than in the general population, including hepatoblastoma, which is in the liver, Wilms tumor, which is in the kidney, renal cell carcinoma, also the kidney, thyroid carcinoma of the thyroid, melanoma, so differences in the skin, and leukemia or blood malignancies. And again, these things are rare, but they're important. So every time your child is seen by an expert in 22q, they're thinking about all of these things. So the 18-month-old who came in and the mom said, you know, when she gets up in the morning, she's limping and she doesn't want to really bear weight on that leg. And she was seen by rheumatology and found to have arthritis and then treated, and the child has done quite well. Now, the 22q11.2 duplication causes similar features to the deletion, but with less frequency. So we see neurologic differences, including seizures and macrocephaly, which is a big head, sometimes microcephaly, but more often macrocephaly. GI abnormalities, including reflux and feeding difficulties and chronic constipation. ENT differences, including, again, chronic infections, ear infections, sensory neural and conductive hearing loss, and laryngomalacia. Endocrine abnormalities, very similar to the deletion, including short stature, although we do see overgrowth in some people with the duplication, which we don't see in the deletion. Obesity, low calcium, and low thyroid. Congenital heart disease, including all of the same heart lesions we see in people with the deletion, but in addition, in those with the duplication, we see hypoplastic left heart syndrome, which is rarely associated with the deletion. And then in terms of skeletal differences, we can see hemihypertrophy, where one side of the body is bigger than the other. We can also see cervical spine anomalies and scoliosis, and patellar dislocations, which we also see in the deletion. And then from an immune perspective, we do see chronic infection and low immunoglobulins. And from a GU perspective, the undescended testes, hypospadias, hernia, and some kidney differences. So again, a very similar approach to what we do in people with the deletion. And here again, for the palate, we sometimes see an overt cleft palate, so a hole in the roof of the mouth. But we also see cleft lip and palate, and we see submucosal clefts in VPI, just as we see in the deletion. But as you can see, in terms of prevalence, it's less common. And again, we also sometimes see some blood differences, including easy bruising, often due to thrombocytopenia. Now, clinical indications for testing for the 22q11.2 duplication most often include developmental delay, or a relative with the duplication. So if we looked at those referred to us, just over half were sent because they had developmental delay, and much less often congenital heart disease, autism, growth differences, neurologic issues including seizures, palatal abnormalities, some mild facial differences, hearing loss, and ADHD. And then we often find individuals to be affected because they had somebody else in their family who was affected. Now, 22q11.2 copy number variants commonly result in developmental delay, cognitive deficits, behavioral differences, and occasionally psychiatric illness, including ADHD, autism, anxiety, and in association with the 22q11.2 deletion, schizophrenia. And this is complicated by broad variability, even within families, including between identical twins, where one would have congenital heart disease and the other doesn't, etc. And I will also say that when you look at the literature and you look at the prevalence of things like schizophrenia in the literature, it's a bit higher than what we see at the Children's Hospital of Philadelphia, but our ascertainment is a little bit different. Even though about half of our patients are over the age of 18 now, we only see schizophrenia in about 10% of our patients, as opposed to what's been reported, which is 25 to 30%. And this just may be because those individuals are working in clinics where they're seeing patients with schizophrenia all the time, and we are seeing patients who we generally diagnosed in infancy. Now, young children with 22q11.2 deletion syndrome have mild delays in achieving motor milestones, with a median age at sitting of 8 months and a median age of walking at 16 months. So really within the normal distribution for when children do this in the general population. But if they have congenital heart disease, their delays are exacerbated, on average sitting 1 month and walking 3 months later than their peers. Children with 22q11.2 deletion syndrome, though, have significant delays in emergence of language, with a median age of first words at 19 months, a median age of simple phrases at 33 months, and we've had some non-speakers as old as 5 to 7 years, but then language comes in and it becomes a strength and the parents forget that they were waiting for them to talk. We do, however, have a subset with autism or autistic spectrum disorder, and there's no question that all patients benefit from early intervention, especially speech therapy with or without sign language, because the most important thing is that the child isn't frustrated and that they can communicate their needs. Now, in looking at children with the 22q11.2 deletion, school-age children generally attend mainstream schools with academic and/or behavioral support, with a mean full-scale IQ in our CHOP patients of 76. You'll see in the literature that it's closer to 70, but again, I'm only reporting the data on our patients. And the majority, or 72% of our patients, fall within the average to borderline range. Importantly, 65% have a greater than 10-point split between their verbal and performance IQ, which tends to bring down the overall full-scale IQ, so it's important that these scores be considered separately because it absolutely impacts cognitive remediation. In fact, only 1% of the general population of individuals with learning differences has this type of nonverbal learning disability. So the schools are really not used to it, and it's important that we do testing and that we are speaking about the child's individual strengths and weaknesses, and that we don't generalize in these individuals. Now, we know that children grow into deficit, so they have difficulty keeping up with their peers developmentally, difficulty keeping up with environmental demands, in particular school, and we have seen a decline in full-scale IQ, mostly the verbal IQ falling to meet the performance IQ, and this may be a precursor to developing psychosis. So there are many reasons that we think children should have their IQ measured periodically, and this is one of them, because if we were to see a change in IQ, then we would want the child to be assessed by a pediatric or adult psychiatrist, and we'd want to get in there quickly if there was any evidence of conversion to psychosis. It's important to know that the full neuropsychiatric phenotype is broad in individuals with the 22q11.2 deletion, and it starts with neonatal seizures, which are usually hypocalcemic, then developmental delay and intellectual disabilities, autism spectrum features and disorder, attention deficit disorder, idiopathic or recurrent seizures or epilepsy, separate from the hypocalcemia, mood and anxiety disorders, schizophrenia and other psychotic disorders, and now we know of associated neurodegenerative disorders, in particular Parkinson's disease. But again, there is variability one individual to another, so it may be that a child or an adult with 22q doesn't have any of these things, or it may be that they have multiple features or just one. And so again, everybody needs to be treated as an individual. And the frequency of associated medical problems varies by age at diagnosis. So we know a lot about children. We know the prevalence of immunodeficiency, the prevalence of congenital heart disease, palatal abnormalities, GI problems, hypocalcemia, kidney differences, not so much thyroid disease, and psychiatric illness. And in adults, those numbers are different or they're not known at all. And so there really are significant gaps requiring additional data. And we can only report to all of you what we know today, but it's important to know that these numbers can always change. And as we begin to ascertain people from the general population through, say, newborn screening or non-invasive prenatal screening, these numbers may change because it may be that we're only seeing those individuals who come to attention because they have a problem. It's also important to recognize that the presence and severity of features varies by age and the focus changes. So in infancy and early childhood, there's attention to birth defects, in particular congenital heart disease, as well as associated medical issues, those beginning early motor milestones, and speech and language. And then as we approach school age, the shifting occurs towards academics and peer relations. And as you can see here, sometimes there's a valve replacement in children with congenital heart disease, but really we're starting to think about school and also fixing the palate. Everybody wants their child to go to school and to be understood by teachers and peers. And then as we shift towards adulthood, we're worried about independence, behavioral differences, and that always looming recurrence risk. Now, speaking of recurrence risk, most deletions are not running in the family. More than 90% of the time, the deletion happens new in the child. But once a person has the deletion, there's a 50-50 chance of passing it on to his or her child. And the child could be more significantly affected than the parent. We're just unable to predict. And the eggs and sperms cells have no memory. So every pregnancy has the same 50% chance of recurrence. If you were to flip a coin 4 times in a row, you may get 3 heads and 1 tails. If you flipped it 100 times, you would expect to get 50 heads and 50 tails. But nobody's having 100 children. So just because the first child had the deletion doesn't mean the second child will not. And we know that the deletion has a negligible effect on reproductive fitness, so the prevalence is likely to increase over time. In other words, we're doing a really good job of fixing congenital heart disease and all the other medical problems associated. So we're seeing more and more children grow into adulthood and ready to have families of their own. And so we have to be cognizant of this 50% recurrence risk and think about planning a pregnancy, including options such as in vitro fertilization with pre-implantation genetic diagnostics, where you can assure that the fetus is unaffected. Now, 22q11.2 duplications, as opposed to the deletion, are often familial. In fact, in our cohort, 63% of families, one of the parents will have the deletion. And duplication, I'm sorry. And many parents have no associated features, making it difficult to prognosticate for the child or make a consistent plan for follow-up. So until specific guidelines are developed for the duplication, we employ those guidelines published for the 22q11.2 deletion, which I will say are under revision now, and in early 2022 we'll be submitting new pediatric guidelines, new adult guidelines, transition guidelines, and prenatal guidelines for publication, which will be available for all of you. Now, these original guidelines were developed collaboratively by the International 22q11.2 community with an emphasis on ascertainment and comprehensive care. And as I said, the 22q11.2 Society, which I mentioned I currently chair, which is based out of London, is currently revising these now for publication in 2022. But as you can see, we've had a number of initiatives around the world really working together to better understand the 22q11.2 deletion and duplication syndromes, including the International 22q Brain and Behavior Consortium, which was a group of 22 clinical sites, and now the Genes to Mental Health Network, also a large group on multiple continents that's working to better understand behavioral phenotypes associated with both the deletion and duplication and working towards better treatment strategies. Now, stepping back a minute, historically, Dr. Angelo DeGeorge, shown here with one of our CHOP patients at St. Christopher's Hospital for Children across town in Philadelphia, first described the triad of features now most often known to be caused by a chromosome 22q11.2 deletion, and this was way back in 1965. And that included low calcium, a poor immune system, and then later congenital heart disease was added. And this was referred to as DeGeorge syndrome, and the word syndrome just means a collection of findings. In 1981, this child with features of DeGeorge syndrome was evaluated by Dr. Elaine Zakai here at CHOP, and the child had the typical triad of low calcium, immune problem, and congenital heart disease, but she also had a cleft palate and a GI abnormality known as a jejunal web. And Dr. Zakai said, well, I think she has DeGeorge syndrome, but she has DeGeorge plus. I think I'll send her chromosomes off to the laboratory. And sure enough, a karyotype was performed in the laboratory of Dr. Beverly Emanuel, and that revealed only 45 chromosomes because that child had an unbalanced chromosome 10 and chromosome 22 rearrangement. And as you can see, there's only one chromosome 22 here because the other 22 is stuck on the bottom of the 10. And that resulted in a deletion on both chromosome 10 and on chromosome 22 because they needed sticky ends to come together. Thereafter, additional patients were also reported to have rearrangements involving chromosome 22q11.2, so the conclusion was drawn that a 22q11.2 deletion was a cause of DeGeorge syndrome. So from 1982 to 1992, visible deletions were observed in about 25% of patients, but the puzzle remained, what about the other 75%? This led to the development of FISH probes in the early 1990s by doctors Peter Scambler in the UK and Debbie Driscoll here at CHOP. And they used a fluorescent light or a DNA probe to attach to the area of interest. So here you can see two chromosome 22s. They used the green light to show that there were two in the cell, and then the pink probe was the 1.2 region. So absence of the pink light indicated that there was a deletion. So once those FISH probes were available, 22q11.2 deletions were then identified in most patients with DeGeorge syndrome. Thereafter, the 22q11.2 deletion was found to be the cause of multiple other clinical diagnoses, expanding the associated clinical features, adding palatal defects for velocardiofacial syndrome, as well as some mild facial differences. Conotruncal anomaly face syndrome, as described by the Japanese, which had the same exact heart differences and some mild facial differences. I reported a subset of patients with Opitz GBBB syndrome, which included patients who had wider spaced eyes, cleft lip and palate, hypospadias, which was again the opening of the phallus was not at the tip but underneath, and abnormalities of the larynx, the trachea, and the esophagus. And then, as described by the Italians, Kaler cardiofacial syndrome, which again was the same heart disease but added asymmetric crying faces. Now, these clinical conditions were all described prior to the association with 22q11.2 deletion syndrome by clinicians concentrating on specific areas of expertise. So Dr. DeGeorge was an endocrinologist, Dr. DeCal was a cardiologist, and Dr. Sprinson a speech pathologist. 22q11.2 deletion syndrome is now the preferred term as the one unifying finding amongst all individuals, because we see lots of patients with the 22q11.2 deletion who don't have hypocalcemia, who don't have congenital heart disease, who don't have immune deficiency, who don't have facial differences, and who don't have any of the other things as described by these clinicians. So we have to say, let's use the term that defines the condition, which is the presence of the deletion, which everybody has in common. So 22q11.2 deletion syndrome is now known to cause additional birth defects, later onset conditions, cognitive delays, behavioral differences, and psychiatric illness, as well as now neurodegenerative disease such as Parkinson's, all far extending the original description of DeGeorge syndrome. And these conditions lead to significant morbidity and some mortality. And they require a multidisciplinary approach to care. So as I mentioned, the 22q11.2 Center at the Children's Hospital of Philadelphia has seen more than 1,800 patients with the 22q11.2 deletion and duplication. It's housed in genetics as at the center of this circle, and we have a primary circle of caregivers, all of whom have significant experience with these conditions. And then we have the extended circle, which really includes the entire building. And there are some children who need the entire building, but most need a subset of the people who have expertise in this condition. And once again, although common, lack of recognition of the condition together with the wide variability that we see in patients often delays diagnosis, which could improve outcomes. This includes in adults with the deletion often identified only following the birth of a child with congenital heart disease. Now, speaking of when do people come to attention, well, in our cohort, the mean age at diagnosis was 3.9 years. But we know that children with congenital heart disease are more likely to come to attention early, often sending children and their families without congenital heart disease on a protracted diagnostic odyssey. And as you can see here, we have people who are diagnosed before they deliver, prenatally, which certainly gives them the optimal chance for the best outcome, because they're delivered in a place where if they need congenital heart disease surgery right away, they go right from the delivery room to the cardiac center. And so trying to optimize outcomes for everybody. So why does this matter? Well, here was a child diagnosed at 5 years. He was described as pokey in the newborn period. He had a history of failure to thrive and gastroesophageal reflux disease, nasal regurgitation, which is never normal when milk's coming out of the nose, and chronic infection. He had delayed developmental milestones, particularly speech, and he was evaluated by a whopping 27 specialists without a unifying diagnosis. But his 2 physician parents, an ENT and OBGYN, were relentless. And a microarray led to the diagnosis at age 5 years. He was subsequently diagnosed with growth hormone deficiency and went on replacement therapy. He was found to have a submucosal cleft and he had a repair. He's been diagnosed with scoliosis. He has a little bit of ADHD. He has a little bit of a learning difference. But his parents really bemoan what may have been missed. Did he have hypocalcemia early on? Were any of the findings treatable early on? And will that affect him long term? And certainly our goal is to diagnose children as early as possible. So what are the benefits of early diagnosis? Well, here are some examples, 2 of which were provided by Dr. Michael Mitchell, a cardiac surgeon at the Children's Hospital of Wisconsin. So patient 1 was diagnosed prenatally by a fetal echocardiogram, had early surgery and a complete repair, just like I mentioned with many of the patients diagnosed here at the Children's Hospital of Philadelphia, and the child was discharged to home and is currently doing well. Patient 2 had no prenatal diagnosis, was discharged on day of life 2, presented on day of life 9 in distress, had a complicated resuscitation, and suffered a stroke. Then came the diagnosis of congenital heart disease, particularly interrupted aortic arch type B, and then 22q11.2 deletion syndrome. The child required multiple additional surgeries and $750,000 in increased hospital charges over the first year of life, and perhaps most importantly, is living with a stroke. Likewise, we saw a neonate in our cardiac intensive care unit. The child had had a prenatal diagnosis of club foot and polyhydramnios, which is too much fluid around the fetus, which we see commonly. At home, he was a little blue. He was transported to the local emergency room. He had a complicated resuscitation and a diagnosis with congenital heart disease. He was transferred to us and found to have interrupted aortic arch type B. That led to the diagnosis of 22q, and he had subsequent complex cardiac management and was found to have hypocalcemia. At the bedside, we met the parents, and mom had a master's degree in education. Dad had a history of a repaired heart difference, in particular a VSD, had a repaired cleft palate, had a learning disability, although he graduated high school, and he had been employed since graduation. Parental studies confirmed the paternally inherited 22q11.2 deletion, and there had been no previous concern by the family or the healthcare providers based on this history. And we suggested that recognition of the diagnosis in the father would have changed management both prenatally and neonatally for the child. So early diagnosis of 22q11.2 deletion syndrome may decrease morbidity, so all the associated problems, and perhaps even mortality, those that succumb to the diagnosis, concurrently reducing overall healthcare costs and making 22q11.2 deletion syndrome a reasonable candidate for newborn screening. And this is something we've been working on for the past 10 years, both in the United States when we attended the Secretary's Advisory Committee on Heritable Disorders in Newborns and Children in Washington, D.C., and in the House of Commons in London, UK. And by the way, this is not something that we only want to identify patients with the deletion. We want to identify those with the duplication as well. Now, what is some of the rationale for wanting to identify individuals with this? Well, 22q11.2 copy number variants are common. They were previously reported in 1 in 4,000 to 6,000 children, but more recently, the 22q11.2 deletion was identified in 1 in 2,148 live births via a newborn screening pilot study in Ottawa, Canada. Moreover, it has been reported in 1 in 992 unselected fetuses, so those without congenital heart disease or cleft palate in Italy, and 1 in 1,524 individuals via an international collaborative known as the SMART study. In addition, the 22q11.2 duplication was also found in Italy in 1 in 850 unselected fetuses. And when we think about the mechanism of the deletion, how it happens, and the duplication, they happen in the same way. So we would expect the same prevalence. In fact, we might even expect the duplication to be more common because we find it so frequently in the parent. So 22q11.2 deletion syndrome is the most common microdeletion. It's the most common cause of syndromic palatal anomalies, so those that are not isolated, the most common cause of schizophrenia, and the second most common cause of major congenital heart disease and developmental delay after Down syndrome. In fact, 22q11.2 deletion syndrome has been identified in more than half of those patients with interrupted aortic arch type B, in 34% with truncus arteriosus, and in 16% with tetralogy of Fallot, making the 22q11.2 deletion a more common cause of tetralogy of Fallot than Down syndrome. And why do I bring that up? Well, frequently obstetricians recommend an amniocentesis to rule out Down syndrome when they find tetralogy of Fallot on an ultrasound. And in fact, they're more likely to find a child with the 22q11.2 deletion. Also important is that 22q11.2 copy number variants are not related to advanced maternal age, so affected offspring are equally likely to be born to young mothers as to those with advanced maternal age. And this is one of the reasons why non-invasive prenatal screening has been developed to try and identify those pregnancies that are most likely to be affected by a chromosome 22q difference. So based on a prevalence of 1 in 2,000, there should be approximately 163,000 affected Americans. And that's based on the 2010 census, including 37,000 children and adolescents. So where are they? And we think perhaps they're awaiting diagnosis. Now, many groups are working tirelessly around the world to change this, supporting awareness, early detection, and best care practices. Looking back, I joined the genetics team at the Children's Hospital of Philadelphia in 1985, and those studying DeGeorge syndrome in the early 1990s. And this work has continued in collaboration with these organizations, but there is still more work to be done in partnership with government leaders around the world. So in summary, 22q11.2 deletion syndrome leads to significant morbidity and some mortality, with multi-organ system involvement, including congenital anomalies, later onset conditions, cognitive deficits, behavioral phenotypes, and psychiatric illness, requiring input from healthcare providers in multiple settings, starting with obstetrics and maternal fetal medicine, cardiology, prenatal genetics, neonatology, pediatrics, surgery, adult medicine, all the subspecialists that I mentioned, and in particular 22q11.2 centers of excellence, where those subspecialists have lots and lots of experience. 22q11.2 deletion syndrome is common. It's the most common cause of syndromic palatal anomalies and schizophrenia, the second most common cause of congenital heart disease and developmental differences after Down syndrome, and a more common cause of tetralogy of Fallot than Down syndrome. And the presence and severity of features varies by age at diagnosis, most particularly congenital heart disease, especially when we look at those diagnosed prenatally versus postnatally. And 22q11.2 deletion syndrome is not related to advanced maternal age, so affected offspring are equally likely to be born to young mothers as to those with advanced maternal age. And this wide variability hampers early diagnosis both pre- and postnatally, delaying interventions and leading to poorer prognoses, sending families and healthcare providers on a diagnostic odyssey. Conversely, early diagnosis, including in the prenatal or neonatal setting, offers medical and emotional preparedness, concurrently reducing costs medically, emotionally, and fiscally related to late or misdiagnoses. So while time has marched on from FISH to microarrays to whole genome sequencing, we have made great strides in understanding the chromosome 22q11.2 deletion syndrome at CHOP and around the world, with the ever-present goal of helping patients and families. But once again, there is always more work to be done. So I'd just like to thank my collaborators at CHOP and around the globe, because it takes a village to care for a patient with 22q11.2 deletion syndrome, and many of the initiatives that we have would not be possible without the willingness of my collaborators at CHOP, who always say yes when I ask them to help out with a patient or family, as well as everybody I work with around the world, the members of the International Brain and Behavior Consortium, the Genes to Mental Health Network, my colleagues in the 22q11.2 Society, in particular Peter Scambler, Ann Swillen, Ann Bassett, Bernice Morrow, Jacob Vortsman, the list goes on and on, Sixto Garcia Minor in Madrid, Nicole Philippe in France, Christina DiGilio, Bruno Marino, and Marta Unault in Italy, and Beata Nowakowska in Poland. And really, the time and effort that these individuals put into understanding 22q. It's more than just work. It's a calling, and these are people who really do care, and it's our goal to make life better for families affected by these chromosome differences. And I'd like to thank the patients and the families for everything that they've taught us, because it always, always begins with a patient. And huge thanks to Stephanie St. Pierre, Stephanie Reese St. Pierre, and Myrnie Rinholm for all they do on behalf of families through Chromosome 22 Central. If you love 22q11.2 deletion syndrome as much as I do, you may be interested in the textbook that should be coming out shortly on 22q11.2 deletion syndrome. It was really created not for families so much, but for professionals, healthcare providers, etc. And it is quite expensive. We don't set the price, it's the publisher. But it may be something that your 22q Clinical Center of Excellence or your pediatrician or subspecialist that you see might benefit from, and you'll be able to find that quite soon. I'd also like to mention 22q Awareness Night, Light the Night Red, which was developed by our colleagues in Spain. These families worked very hard to get monuments lit up red on 22/11 in Europe, which in North America we say 11/22, but November 22nd will be Light the Night Red evening around the world, and as you could see, there were monuments lit all over Europe. We were able to join them last year in Philadelphia, and we had many monuments, and the Children's Hospital of Philadelphia lit up red on November 22nd, and we plan to do it again this year. And then I'd just like to remind everybody that the 12th anniversary of 22q at the Zoo Worldwide Awareness Day should be coming to a zoo near you on May 22nd, 2022. We have been remote and done 22q and Zoom for the last 2 years, and our hope, our sincere hope, is that we'll be in person next spring. If not, we'll do another Zoom event, but it's a really important day. If you're not familiar with it, it starts in New Zealand at 11 a.m. and then goes to Australia, and then works its way across Asia, the Middle East, Africa, Europe, and then comes across the Atlantic to the Eastern North America, and then goes all the way across North America and ends in Hawaii at 1 p.m., literally having circled the globe on behalf of 22q awareness. And it's also a friend-raising activity. There's no fundraising involved, but it's really a day for solidarity and support, and I know that the kids really look forward to it as much as the adults. And then once again, if you love 22q and you're able to travel, the 12th Biennial International 22q11.2 Family and Professional Conferences will be held June 26th through July 1st, 2022. So next June and early July in Split, Croatia. This was a meeting that was supposed to be held last summer and would have come to North America next summer, but because of the pandemic, we couldn't hold it. So we will be in Croatia next summer. June 26th and 27th will be the family meeting. And if you can go, I would encourage you. It's a meeting where experts come from all over the world to meet for the scientific meeting, but they come early to speak to families. And you can find all of the information at 22qsociety.org. And then lastly, we just had 22q and Boo, which is an event that we have every year here at the Children's Hospital of Philadelphia. It's a Halloween party and educational seminar for families. And you can see that we were Snow White and the Seven Dwarfs in 2019 now already. And then in 2020, we were Where's Waldo. In 2021, we were 101 Dalmatians, and we hope again to come back live and in person next Halloween. And so we would invite you to join us. And now that we know how to do things virtually, we'll probably have a hybrid event for 22q and Boo next year. So that's it for now. I'd like to thank you for your kind attention. I'm so delighted to have this opportunity to speak with you. And I would just like to say, please, please, if you have any questions, don't hesitate to reach out. McGinn@chop.edu. We also have a 22q email, which is 22q@email.chop.edu. And if for some reason you don't reach me at mine, you can try that one. But because I can do email in the middle of the night, I'm much better at email than I am at telephone calls. So just a pleasure to be here, a pleasure to be celebrating 22q Awareness Month. And I wish all of you a very happy and healthy 22q month. And please, please stay safe for the remainder of the year. And I really do hope that I can see some of you and welcome you to Croatia next summer. Thanks again, and all my best.